This is the Situation Room, the only way to start your day.
There is a husband perspective and a child perspective. As Beatrice is putting it, the child has a good mother and only think that she's also a good wife to their father. Until the father say it, you should not perceive as such, because it is only the first experience that can tell what I know. And this is in respect to how we have government officers telling us what is working instead of letting the people tell them what is working for them.
How they're experiencing it.
Yes.
Okay, well, no time like the present. What's going on? It's a year plus. October 1st is when we saw another Cabinet Secretary for Health establish the Social Health Authority fully and start bringing the crossover between NHIF and SHA. And we saw that happen, and then there were hiccups. They told us teething problems, but we say, okay, even at some point, the teeth will grow and then we'll stop. But apparently we've not got past the teething problem stage. But what's going on until now? From where you sit, what's the issue?
I think we have had a very challenging experience. The Ministry of Health has had actually change over guards for close 3 ministers being changed, including even PSS have also been changed, not once, not twice. So to that, it can only tell you how it has been difficult actually to manage the Ministry of Health and the expectation that it had. I think it takes us back in terms of the promises the president gave to Kenyan, and probably his desire to fulfill his promises. Now the question is whether we are on the right track or we missed the track. And I think that's why you hear, and rightfully, the question that you are posed to us, then explain why Kenyans feel differently, majority of them, and the government tells a different story. And it takes us back, give us a refreshment in terms of what the president was addressing during his nation address. And he told us of the success story. And without mentioning the challenges, as you will have mentioned, that we have experienced as well, some challenges in 1, 2, 3 areas. Because he had several points that he promised Kenyans. That he established a financial system that will cater for everyone, that will leave no one behind. And also he promised that he was going to establish a free primary health care services from level 1 to 2, where then there will be a fund to do that. He promised a number of things: establish employment of 20,000 healthcare workers.
Yes.
And that was expected within the first 2 years. He also expected to build 6 level, five level 6 hospitals.
Yes.
And also elevating level 5 to be the center of excellency for the same. He also promised to push for home-based industrial manufacturing for home product that we can actually leverage to lower the cost of medication. So there are a number of them, including the digital health that he promised. So those are some of the promises, the key points that he gave to Kenyan. And the Kenya trusted that this was really speaking to their situation, because we had a challenge with NHF, which was actually struggling and only catering for very few. We had a lot of challenges, including corruption, that was actually threatening the NHF then. Now, his promise was also to tackle the issues of untamed corruption. And that's some of the questions that we are here today to discuss,
right,
whether we're making progress or not. Yeah.
Well, Senate seems to think that progress is not being made, and not seems to think. This is also drawn from the experiences of Kenyans across board. The Senate last week had a session where SHA was the subject matter, and that it would appear as though there are a number of people who go to hospital today. There are those who are held in and their children with their children. Mothers will not be released because they can't pay. There are those who have a huge bill and SHA is only paying a minimal percentage of this. There are those with bills of 800 plus thousand and SHA is ending up paying paltry 86,000, things like that. And these are stories that are happening across board. The president also was very clear in public when he said that if anybody asks you to pay,
Call me.
Me personally, why should they ask you to pay? So there seems to be an understanding from the executive that this is a service that because you're registered and paid up, we should offer it to you for free. But it's not happening, Beatrice.
Exactly. What we need to understand is that UHC is being used currently as a political tool and to settle political scores. That's a problem. And healthcare is actually being politicized. It's becoming a political tool where it can hoodwink the citizen. But the reality is when you use healthcare as a political tool, lives will be lost every single second, every single day. And that is something we need the government to try and understand to stop politicizing health. Now, when the president stands and says that SHA is working, the Kenyan citizens are wondering how. This is because SHA is not collecting enough contributions. His students said 27,000 Kenyans have been registered. But I would like to pose a question to SHA, how many are principal members? Because the 27 million Kenyans could actually be inclusive of beneficiaries. Because we saw with NHIF, it was covering around 22.8 million Kenyans, but the principal members were 16.7 million. So that, and those who are contributing were actually 7.1 million. That is for NHIF. So these 27 million numbers of registered people he's actually quoting, we need to understand how many are the principal members. Then on top of those principal members, how many are contributing? So right now the data, those who are actually contributing are 5 million. Remember, based on the KNBS data, they showed that 3.1 million Kenyans are the only ones who are formally employed. And the same president also said 2.3 million Kenyans who are indigents. These are people who are the poorest of the poorest, that the government is actually paying for them. So when you get the 2.3 and the 3.1 formally employed Kenyans, that come to around 5 million. So now we are wondering where are the rest of the Kenyans who have been registered? That's 27 million. They need to tell us who are the principal members. It seems they are non-paying. They are actually not contributing. That tells you SHA is actually not collecting enough. So if it's not collecting enough, that's why you find the case scenario whereby people are being detained because SHA is not paying. Or you find that you went to a facility, you actually got the services, but the healthcare provider has not been paid. So we are finding facilities almost shutting down because operations cannot run concurrently. Why? Claims have not been paid, backdated. So the only way the SHA is actually paying is just little bits. And then remember that NHIF also had a 30 billion debt that they owed these healthcare providers. So these healthcare providers are wondering, how can we keep on providing services to Kenyans, but we are not getting paid? So you only know that a system is working whereby the person who is actually providing that service, that financial or that system is actually being able to pay. Remember, we have the COG, the chairman of COG. He was saying they want to abandon this whole wagon of SHA. Why? Because the government also owes a lot of money, that is billions of shillings. I think it was around 10.5 billion, thereabout, to these, what we call the facilities, the county facilities. These are public facilities. Yes. So when now you go to the private sector, if you are a private sector, that means you are not doing services for free, or you're in the business. That's the reality. But you see, for public facilities, they may not be in business because it's government. So there is no way I can operate a hospital based on water. I need money. So when these Kenyans walk into these private facilities and the government owes these private facilities money, they will definitely turn them back. But then the president comes and says that he's going to, anyone who is turned back, call him. Now, recently, we saw a very famous musician, Betty Bayo, dying. And we saw UDA MP saying that William Ruto contributed 2 million. And then we saw another mother of another famous musician also dying, and William Ruto contributed 1.5 million to cover the bills that were incurred by these individuals. So it reached to a point, Kenyans say, it means William Ruto's system is actually better than the SHA system. So Kenyans should actually contribute to William Ruto. Maybe that can actually work to solve their problems. So already, if the president has to contribute money so as to sort bills for a prominent Kenyan, what about that Wanjiko on the ground who doesn't know the president or does not have well connected individuals? It means people are going back to their pockets to actually pay for these bills. And you'll be shocked that the second leading contributor or expenditure when it comes to healthcare is actually out-of-pocket expenditure after government. That is in an alarming rate, because when government is spending around 32% of the covering 32% of the healthcare expenditure, the out-of-pocket expenditures around 28%. That is huge. Then the donors come in at 20%. So that tells you that Kenyans are paying more. Actually, per year, we are spending around 150 billion, where Kenyans are actually paying for those healthcare services. That's still a very, very huge gap. So what that tells you, now that the donors withdrew, so it means the 20% is already gone. So when the donors withdraw, who is going to spend more? Is it government? And we can look at the budgeting that they have done. They have not allocated more funds. So it means the Kenyan goes deeper into their pockets to actually cater for that deficit the donor has actually left. So that's how the healthcare system is at as we are speaking today.
So Beatrice, the state of healthcare, where have we lost it, or where are we losing it? Because based on the statistics and the data that you are presenting,
yes,
you began by saying it's being politicized.
Yes.
Is it a gap between policy and practice? Because they have told us that even our system has been, borrowed from other jurisdictions, and that we are aiming at making it better.
Yes.
But the experiences of the beneficiaries are not commensurate. They are not in tandem with what is expected in policy.
Yes.
And yet we also have very strong institutions.
Yes.
You quoted KNBS that is supposed to guide and advise on policy.
Yes.
Where have we lost it? Or who is not speaking to the other, and what therefore must we do to better it?
So we realize that policies, if they come with an idealistic, like an ideal setup. But the reality is there's no situation that is ideal. So long as you're dealing with human beings, there'll never be any ideal situation. So there's a lot of rigidity of the government's not tailor-making. For example, one of the suggestions we gave, the proxy means testing tool is making Kenyans shy off in terms of paying or doing the contributions. The reason why NHIF was making progress is because the contribution was predictable. Because of our informal setting that is huge, over 60%, Kenya needs some predictability. But with the proxy means testing tool, there's no predictability, because today they can tell me to pay this much. The next year I go use the same proxy means testing tool. I might end up paying another different amount. But with NHI, because of that predictability, people are able to budget, people are able to manage. I'm able to pay for 5 other people because there's some predictability about it. Remember, we're still an agricultural economy. So it means the farmer also goes with seasons. So he also needs to budget himself and plan, so that if his crops fails, he can be able to ask himself, where can I get an alternative? Budgeting, maybe if it's, for example, if it's 700 shillings every month I have to contribute towards my healthcare, then I can budget it and I can be able to multiply it and be able to pay for it. But because the way the policy has been set up, there's a lot of unpredictability with this policy around healthcare financing. Number two, we also look at the benefit package. People are not sure how much will they pay, how much will be funded for me. You go expecting the government is going to pay this amount of bill. You're told no, we only cater for you this amount, this much amount. So lack of that predictability of a system, especially in our informal settings, what happens is that people will shy off. Remember also, when we looked at Linda Mama, for example, people were aware that Linda Mama is being paid for government. All I need to go as an expectant mother, I just go and deliver, and the government will take care of it. Now, when mothers go and they are detained, what happens to the women in the village? They'll decide I'll no longer go give birth in the hospital. So we are going backwards, even when it comes to maternal mortality rates and also neonatal mortality rates. So we end up going backwards because now people are not sure, if I go, will I be paid for it? And will it work? Will it function? Then the other thing is as systems. You realize that most of the systems are always downtime all the time. So even when you walk into a facility expecting things will go smoothly, the healthcare provider tells you the systems are down. So you ask yourself, what was this new system that they were integrating or bringing on board? How come 1 year and 1 month later, it's actually not functioning? So we need to go back to the drawing board, and what I can suggest to the government is let's make this SHA predictable. And that's why most of the stakeholders were giving them and telling them, okay, fine, because we look at our current status economically, 92% of the tax revenue being collected is actually going to debt servicing. So 8% is what is remaining for the government to do development and recurrent expenditure. So you can ask yourself, from that 8%, how much can this government afford even to actually set aside for healthcare? So that tells you, still as a country, we'll still have to do some premiums. We'll still have to do some contributions. But these contributions, they were asking, why can't we do some capitation so that people can have the predictive, and he'll be able to bring a lot of people into the pool of SHA. But now, because there's no predictability, most people will shy off, because they are now, I might go be asked 1,000 shillings and I'm not employed, but I live in a, you know when they use those standards, I live maybe in a tiled roof, or I could actually be living in a prominent household, but I may not have any income. So because of that fear, most people are shying off to actually contribute towards it. So they need to redesign.
So Gibora, when you look at it, that yes, there is the registration aspect, but there's also the payment, that in terms of those initial premiums, we need to pay them. And are we dealing with an issue whereby there's not enough money, as has been established, because not everybody has paid their premiums? Is that a primary issue first?
That is a key issue, a primary problem. And I think why we're here today is to do a reality check. What was promised, what is the law, and what is the reality. Now, when we look at it, the Social Health Authority establishes 3 funds. The primary health care funds, we have now the chronic critical care and emergency funds, and also now the Social Health Authority funds. And the Social Health Authority Fund is expected to cater for facilities level 4 and above.
Right.
For all the lower facilities, it is level 3, level 1, that's 1 to 3, is for primary health care funds, where the government say it will be free. The free aspect, which we as the practitioners, when you use the term free, we question it because it's not applicable. It's a political statement, so to say, because then there is no medicine, there's no Medicare, which is free. It is actually putting our money at tax collection into use and paying for the people. Now look at it. When this Social Health Authority came, what did the government promise? In their own actual study, they said for you to begin, or rather to roll out the primary health care, they needed 70 billion. 70 billion for that financial year. So how much did we allocate? It was less than 6 billion. So then following year, now the financial year 2025, 2026, I think primary healthcare has around 13.5 billion. So is that money that can now, what is the percentage of the real projected figure versus what you're putting there? So that's why you create a gap between the demand versus what you have input there. So facilities have served the patient. They are requesting for money. You have not allocated any resources. There is a gap there. But also, what does the Social Health Authority say?
Sorry, Gibore, this 70 billion, is this aside from the premiums that people who register would be paying?
No,
or
this is purely primary health care, which the government was to subsidize,
exactly.
pay.
All right. Okay.
So it was to come through a budget.
Right.
So the budget has never been projected as such, not even halfway. So then it creates a gap in terms of now the demand versus what you have.
Okay.
So then that is why facility are not able to receive the money that they have worked for. That is a reality.
Yes.
Now, when you talk about the number of people who have been registered, talking about 27 million, it is true that they have registered. Are they subsidizing? Are they paying their premium? So the people who are religiously paying are those who are in formal employment, who are around 7 million. So then the 20 million, all of them, once they have registered, then they have a right to access the primary health care fully. It is only, they are only demanded to be now paid up for them when they are assessing the services beyond the level 4 and above.
Yes.
That's when we now check. Now, I was talking about how primary health care is now creating a big gap and a problem for the government by virtue of they have a reality check. They did their own actuarial and said this is the money we require, and they never inputted that money there. Now, that money is the one that giving the problem, causing the problem between the employer, the government, and the practitioners.
Okay.
So, two, the government projected to ensure that they can support those who are vulnerable. Our expectation was when we are doing this exercise, it will be a transparent exercise so that then we know how many people have been found. What are the parameters that inform that Igibore is vulnerable? We know, yes, those are the extreme age, and also those who cannot be able to raise anything. Because you could also be in extreme age, but you are rich, you have money.
Yeah.
So who are these? We wanted to know when the president come out and say we have now close. He talked about 1.8 million, 1.3, who are already on support by the government. 2.3. 2.3. Who knows them? How did they come on board? Who onboarded them? Did people participate? Because the Constitution anticipates stakeholders' participation.
Yes.
Or is it a way of siphoning money from people? Let the government come up tomorrow, declare and publish the people who are benefiting. For me, who come from Korea, I know that so and so. I know mothers, people who sleep on the floor without anything covering them, but they are not still benefiting. How did we come up with the people who are benefiting? I expected after a rollout, and even this will have actually happened because then it was the government project. So that then, before we rolled out the Social Health Authority, we'll have actually mapped out all the people who needed the government support and then published it for either contestation or support by the public. Now, this did not happen. All these things now are happening. You hear that the Minister of Social Protection is working on what and what, but it is not known where they are doing this. So then we have a big question in terms of the people said to be supported by the government or under government cover, and we don't know who they are, and the amount that has been allocated to support those people. So let us see some transparency, because when we complain about corruption, are dealings that are siphoning money and intending to benefit people, but people are not getting the benefit. So if today you say people are benefiting and we cannot even point out to anyone who is benefiting, especially we as the Kenyan, I think this is where you were saying about the child believing that the father has a good wife because she has a good mother. The president must not be listening to the choir, the choir that he has around him, because they probably lie to him. And they are probably building their own network to siphon money from the Social Health Authority and the money that we have raised through sweat. So if then we needed to know that annually, the system that he was building in terms of digital health was supposed to actually tell us the reality. Kama mimi, for instance, the KEMSA ought to see which drug today I have imported, at what cost, and at what cost am I sharing it to the counties so that Kenyans know what is it that it is happening.
I thought this 104 billion shilling digital system, it was supposed to do just that, in addition to all of these other things, where we're able to say that 27 million people are registered for SHA, 7 million people is guaranteed because this comes from formal employment. Right. From the remaining 20 million people, we should actually be able to see through this digital health system that, because remember, we've had a number of cabinet secretaries in health in the last 1 year, but under Dr. Baraza's time, they told us very clearly that we would then, through this digital health system, we would then be able to see who paid up, who not paid up, who then has started, maybe has not started, is waiting, who is indigent, all of these things, we'll be able to see. What you're saying is that you spent the money on this system, but it is not producing what it was promised to produce in the first place?
Precisely. That's what I'm saying. We're doing a reality check. What did you promise? What are you doing with it? Today, you find government officers who are very irritable. That you ask something which is a reality that, let me say, we saw when they tried to do that transparency, like how many people have been enrolled, you can check how many people have been paid this month, and people started unearthing, like for instance, facilities that were receiving money without any service, and some of them not existing. They went and closed that. Now you are not able to check who received money and how money moved.
Why?
And these people who are in energy, you'll hear the CS coming, and they give a list of people who are stealing from the Social Health Authority without taking any action. And you must get to understand that you cannot steal from outside without someone inside aiding that. We have never seen him announcing anyone aiding the same in the ministry. He listed facilities which were not existing but receiving money. Has he taken action up to date? No. So could he be accomplices of the same? Is a question that Kenya need to answer. Need to ask so that he answer to it. I saw like the chair of the Social Health Authority being questioned. He protected him. Up to date, Kenyans do not know whether he is an accomplice of the facilities that were opening in Mandera, Garissa, a number of them. And today, we have no answers as Kenya. And that is why people continue doubting and have a lot of mistrust with the Social Health Authority, because then when a question comes, there's no one to answer. You are so irritable, you just throw tantrum at everyone who asks you a question.
So Banagibore, therefore, because you're also a union leader, and you engage with the citizens, both at the point of delivering the service as a clinician and also at the point of the policy process, like you engage and you are a main stakeholder. What is therefore the level of confidence? Because sometimes they'll tell you SHA is working. We know SHA is not working. Sometimes they will tell you the system is down. And the experience of most Kenyans, even today, is you walk into a health facility, you are not sure whether you are going to be attended to, whether you are registered within SHA or you are not registered, whether they will pay or they will not pay. What is the level of confidence? Of course, you've said severally, it is not working, it is not working. But as you engage with the point of service delivery and also the citizens who are listening to us today.
Yeah, total disconnect between the policy and the governance. Those who are supposed to implement the policies that exist. The policies, if you look at it, if they were to be implemented point by point, Kenyan will just be the one to say that it is working. So don't shout for us that it is working, because for the last 2 weeks, I've been receiving complaints from just now the practitioners, healthcare workers, who are paid up members, but they are not able to access services. One is because they are supposed actually to be enlisted as what do you call? We used to have under NHF a comprehensive cover, which was transitioned after negotiation that this was to cover them continuously. Today, every time our healthcare workers go to seek any services, they have to supplement from their own pocket. How do you tell me we can continue trusting such a system? without any explanation, without any communication, that this either has been reviewed upward, downward, whichever. So that is creating a gap. Yesterday I was receiving a call from Trans Nzoia. I received another one from Mombasa and another one from Marsabit. On the same, the people are being asked to subsidize their payment. So, and you hear people talking about what is working instead of going to the field and telling us that there is a problem where they sort it. Now, I can give you a good example of someone lost his, he was a civil servant, and the family, that gentleman died because of liver problems.
Yeah.
And they required it to pay around 3M because the patient was in ICU for more close to 2 months. The NHF, I mean the Social Health Authority only paid 800,000. So close to 2.2 million fall back to the family. We were being gathered kwa pages to contribute. So then the president should tell us, should we call him so that he subsidize this, or what should happen? I have the document. I shared with the CEO SHA, and she gave me someone to who will work on that. Up to date, they have never responded. I even informed the family to write formally to the Social Health Authority. They have never responded, and the committee has never finalized in follow-up. The issue was with the Mater Hospital. We had to negotiate for them to raise the body so that the family can have a send-off. Then they settled the bill. We are still fundraising up to date, a month down. How do you tell people to trust such a system? That I was a fully paid up person, but then when I need services, I cannot be able to access it. Because why civil servant used to trust the NHF is because there was no such issues. When because you are under comprehensive cover, when you have an issue, approval has come, you will be fully covered.
As long as you have the card.
Yes.
Yeah.
So there is no trust, and I can say I don't know whether to rate it 4 out of 10, because if there is any trust that you can trust, you have to trust yourself that maybe you will receive a minimum services, but it's not there. But again, when a facility, public facilities, we talk about improvement. We expect drugs. We expect working laboratories, which are not working. We expected that when I visit those lower facility, I have staffs to work. We have not employed any staffs. We have facilities like here in Nairobi, close to 22 facilities that are non-functional because of lack of staff. So how do you tell me to trust such a system?
So when you meet with these policy makers, somebody like CS as a union official, and I feel what you're saying, and this is largely what we are feeling as Kenyans. This thing is not working. And you said that the policy makers play in bravado, like it is as if they're living in another world. George, what must we do as a people?
I think I think life is like one day long. So you live once. If you have my brother, we share a platform where we have to say it the way
as
it
is. Yes.
Because in any case, there is nothing that you'll be promised that has not come today. Then you will wait to experience it tomorrow. If you need services today, you need it today.
Now, especially health.
Yes, yeah. I have lost for the last around 5 years. I have lost people who are close to me, who I know from their diagnosis up to their departure because of cancer, close to 5 people. And all of them, most of the time, they leave family in a devastating situation because of the money they have to sell even plots to cater for their services. So up to date, you still promise that we are going to ensure that you have a certain amount increased for you to get services.
Yeah.
By 1st December. That's what I saw the president saying. So I say, the person who needs services today, and you are a paid up person, why must you wait to December when you are not alive?
Yeah.
These promises must be realistic.
Yeah.
If then you know that it is not working, don't say it. If you say it and it's not working, you are telling us not to trust you. That is the simplest way I can put it, so that the president need to relook go back to his advices. Are you advising me on the right path? Am I really making sense in terms of what I'm promising? Because we have good policies. I can say we have good policies.
Yeah, implementing.
What is the problem? Do we have people who have goodwill to implement the policies? A big question, and I doubt whether there is.
So,
The
Beatrice,
PS
okay. Sorry, Beatrice, so I'm just in a question here, and it just triggered my mind. Is it possible that this plan was overambitious and that there really just truly is not enough in terms of resources for all of these things to happen commensurate with the promise? Is it possible?
Yeah, it was overambitious.
Okay.
As I had clearly indicated, if 92% of your taxes you're doing debt servicing, 8% is what is remaining, you're overambitious. Then we have to agree. Curative services are damn expensive, especially for African setting. We have to come to the reality. They're damn expensive. We cannot afford. So what governments need to focus now is preventive health. And this is where even county governments should actually do budgets of preventive health. I've heard you asking Gibore, what should we as Kenyans do?
Yeah.
What I would encourage every Kenyan, go the preventive way. You have good teeth, you eat sugar, brush them. It's cheaper. It's actually way cheaper. You like eating fatty foods, make sure you hit the gym. Make sure you do some running. Make sure you do some exercise to prevent the non-communicable disease. That's the only way. It is cheaper that way. I would encourage county governments, hire nutritionists to go to the communities. Actually, that's what Cuba actually resolved to. When they talk about family doctors, leading 150 families within a community, because they're able to walk into those communities, tell them what food to eat, tell them how to prevent some of these cardiovascular diseases, do the diagnostic testing. Let's give credit where it's due. The president talks about the community health promoters going to the households, testing them, testing communities, their blood pressure, testing their just those simple body checkups, which is good. Those are diagnostic tests. But before your pressure is high, can we have nutritionists on the ground actually being employed and actually teaching people on what to eat, on how to prevent these non-communicable diseases, because they're the ones raising the high burdens. The other thing the government should start focusing is the social determinants of health, because these are non-medical factors that actually determine our health outcomes. The reason why you'll be healthy for a longer time period is where do you live, what kind of water do you access. You cannot come and tell us that you're promoting health and or for example, under 5, where maybe diarrhea is the common cause, but the government is not bringing water. So if we are borrowing so much money, let it be to improve the social determinants of health. Let's see water accessibility in these constituencies that lack water. Let's have playgrounds being created so that children, instead of getting childhood obesity, they are actually able to playground, but to actually play, instead of seeing people grabbing land that is actually should be used by the individuals to use as playgrounds for these children. So we have to think preventive now more than curative, because the bills are piling up each and every single day. And when I know you asked him why SHA is not able to meet the reality. Remember, when you have a deficit, what do you tell people who have 2.3 million bill? They will keep quiet. Why? Because whatever I'm collecting, maybe the requirement is 116 billion, but I have a deficit of 48 billion. Who will cater for the 48 billion? And I've already shown you 8% is what is being remained after for the tax revenue. So let's go preventive. That's the only way out for every Kenyan. So think about well-being checkups. They are cheaper, they're easy, because maybe a checkup will cost you maybe 10,000 shillings. It's better than you coming to pay a bill of 800,000 because you have cancer. So if it's diagnosed early, or if you realize you are already healthy, you're able to maintain that health status for a prolonged period of time. That's our only way out as we speak currently. Any government talking any otherwise, they are just actually lying to you.
Let me say, contest the position whether they were ambitious or not. I think the constitution is deliberate. If you look at our constitution, I will start with Article 43, which actually give the right to health, which is a bills that you cannot restrain or rather stop anywhere. But Article 21 also obligate the state. It is the state that has the responsibility to meet my needs, health needs. Then you move to Article 47, the consumer's right, which actually gives also the safety on how we need to get safe safe and quality healthcare. Article 53, the right for children to access nutrition, shelter, and health. So health involves very many multi-stakeholders. If you go to 186, then that is the fourth schedule where division of responsibility now goes. So who has the responsibility? Under the Constitution, when you realize that this could be a problem, the state is given full responsibility. Whether county is not working or not, the state must take responsibility. And to that extent, there is no overestimation of ambitions when you are implementing a constitutional responsibility. How much are we talking about? We are talking about now a projection of how Kenya need to be like Singapore, a use of more than 5 billion. 5 billion, if I was to look at the amount that was projected in 2023 before the rollout of this thing we call the Social Health Authority, was close to around 700 billion for us to ensure that we have a working system. We have a revolving funds that can ensure that our facilities are working. Now, 700 billion for health, to ensure that our health, our state, our people are healthy, accessing health. When you talk about UHC, is a vehicle that need to come with very many things to help you access services, ensure that you are healthy to contribute to the economical development of a country. So there is nothing like of ambitious. We must say that we are only lacking goodwill to implement the policies that we have put in place to benefit our people, probably for our political position. And I don't think that our country is unable. So if we talk about corruption that is untamed, if we were to say, let us concentrate on killing corruption, we have enough money to drive. The former president said we lose how many billion? 2 billion a day. What he did not tell us is where we lose this money to. Now we have another system which tells us money going to non-existing facilities and people stealing from SHA. It's a poorer system. So if then it tells us this is where we go, if you are to compute, the money is even more than 2 billion that the president, the former president talked about. Can we seal the loophole? We have enough money to roll and ensure that we meet the promises that we gave to Kenyans. Yes.
And as you talk about loopholes, George, pending bills to facilities, payment rates, private facilities, public health facilities. What is this? What is, and especially in the backdrop of access to services, where we have the policymakers going out of the country to seek, healthcare, and we are left here. Those of us who cannot travel, who cannot even, get to private facilities. What does that really show for goodwill, which you are talking about?
I think the politicians have realized that Kenya is so gullible. And that is why when we were campaigning, I was in the same camp with the president, where I contributed a lot into his manifesto with the Rigiji. Today, Rigiji tells you the president is the enemy of the country. So who is Rigiji? So he's the angel? He's our God? So he is the one to save this country? No, totally no. There is no politician who comes to you singing. Look first into their history. And that is why the student of history will look back and say, if this is how it has been going, I think you're not the right person. I don't know whether really today in the people who are said to be big politicians in this country, there is anyone I can point to that has a goodwill to fully implement policies to benefit the poor Kenyans.
But
for them, it is more of a status quo. Rather than transformational institutions that can help Kenyan to get the services the way they need it. So as I look at it, all of them have been going out for medication. So if then we were to entrust our institution and they say, I will be coming to Mama Lucy for my medication, even starting from a governor. If we were to take a list of how many governors are going to seek medication outside there, and they promise, and they are telling Kenyan how they have provided good facility for their people, I think I've heard the president using a very derogatory statement against Kenyans who criticize him. whether they are his enemy or not, then those are the names we need to be calling our politicians, because they mean nothing good for us. So, as you have said, until that changes, that a president from Tanzania who is sick can trust to come to Kenya for treatment, but not any of our politicians to trust our facilities. I think we have a sick mentality.
Beatrice, your economic.
Yeah, for me, I would say our healthcare problem is an economic issue. Until we solve our economic issues, we'll never solve our healthcare problems. Why am I saying that? The politicians must understand when 60% of young people or majority of Kenyans are unemployed, you can be assured nobody will manage to pay those premiums. So that's why I say it's an economic issue. We also look at the political economy of this country. Until we'll solve that aspect, we'll never have good healthcare systems. And when you look at countries like Belgium, when you look at countries like China, the Singapore that the president keeps talking about, look at the wealth index of those individuals on average. So you cannot tell me where 40% of Kenyans are living below the below the poverty line. That is $2 a day. That is 200 shillings a day for those ones in urban areas, and 130 shillings those in the rural. And this is the same individual you want to tell them to give out their 50 shillings or maybe 100 bob to give to SHA. It is not possible because there are a lot of competing needs. So there is an economic problem which we Kenyans have to actually subject our leaders to.